Welcome to Pathology Pebbles. I am Dr. Aravi, MD Pathologist. Today we will cover basics of anemia with images of peripheral smear. If you like the paper, kindly subscribe, like and share. Do RBC disorders confuse you? What is microcytic, macrocytic, normocytic? All sound similar? Let's simplify RBC disorders and you will never mix them up again. We will cover classification, morphology, key example and summary. Starting with definition of anemia. Anemia is insufficient RBC mass to adequately deliver oxygen to peripheral tissue. As RBC carries hemoglobin, hemoglobin delivers oxygen to peripheral tissue. And to establish presence of anemia, we have to measure hemoglobin concentration, hematocrit and RBC. Moving on to the classification of anemia. So mainly it is divided into the hypoproliferative and hyperproliferative. So hypo means less proliferation, decreased production of RBCs, and hyperproliferative is increased destruction of RBC. So in detail, if we see, hyperproliferative anemia is a type of anemia caused by the bone marrow's failure to produce enough RBCs, while hyperproliferative anemia is a type of anemia whereas bone marrow is actively produce RBC as an increased rate due to the significant RBC loss or destruction due to the hemolysis. It is body struggle to keep up with the loss of RBCs. Now, hyperproliferative anemia, it is divided into the based of MCV in microcytic, normocytic and macrocytic. For microcytic, where there is a MCV less than 80, so size of RBC will be small. So we will remember by mnemonic SITA. S for sideroblastic anemia or lead poisoning, I for iron deficiency anemia, T for thalassemia and A for anemia of chronic disease. Normocytic anemia, when RBC is of normal size. Examples are anemia of acute blood loss, or renal failure or marrow failure. While macrocytic anemia, when there is a MCV more than 100, so there will be presence of macrocyte or macroovelocyte. So trick for this is Lahore Medical College. So L for liver disease, H for hypothyroidism, Medical College, M for megaloblastic anemia or vitamin B12 deficiency or folate deficiency, and C for cytotoxic drugs. For etiological classification of hemolytic anemia, it is explained in detail in my G6PD deficiency video, link given below. Now moving on to the each anemia in detail. So first is most important anemia, iron deficiency anemia. So causes can be poor diet, lack of the iron and chronic blood loss. Mainly peripheral smear will show microcytes and hypochromic RBCs. We will see peripheral smear in further slides. Key feature is pencil cells and target cells, and labs will be hemoglobin will be low, ferritin will be low and total iron binding capacity will be higher than normal. So for identification of microcyte in peripheral smear, compare the size of RBC with the nucleus of small lymphocyte. So one nucleated cells is seen in peripheral smear, it is lymphocyte, and other RBCs are microcytes. If size of RBC is less than nucleus, then it is a microcyte, and if it is more than nucleus, then it is a macrocytes. The picture depicts elliptocyte, pencil cell. It is seen in hereditary elliptocytosis and iron deficiency anemia. Now it is a target cell. It is seen like a target shape, and in this image we can appreciate nucleated RBCs in upper side, in lower neutrophil, and others arrow showing target cells. It is seen in thalassemia, sickle cell anemia, iron deficiency anemia, liver disease, and after splenectomy, removal of spleen. The cell shows teardrop cell or dacrocyte. It is seen in iron deficiency anemia and myelofibrosis. Myelofibrosis is a fibrosis in bone marrow, and the cell is having shape of teardrop. So this is very important table for comparison of all the four microcytic anemia, SITA. So sideroblastic anemia. So main difference is there will be increased iron as compared to three others. And in thalassemia and iron deficiency anemia, there will be decreased iron, but RDW will be increased in thalassemia as compared to iron deficiency. And peripheral smear will show target cells. While anemia of chronic disease have decreased all the parameter, and basophilic stippling will be seen in anemia of chronic disease and sideroblastic anemia. This table should be revised before the exam. So the another important anemia, megaloblastic anemia, it is due to the vitamin B12 or folic acid deficiency. So mainly there is a macrocytic RBCs and hypersegmented neutrophils. So there will be neutrophils will be more than 5 lobes. Cause will be poor diet or malabsorption. Left finding will show increased MCV and decreased vitamin B12 and folate. Key features are nucleocytoplasmic asynchrony. So what is the nuclear cytoplasmic asynchrony? Due to deficiency of vitamin B12 and folic acid, there will be defective DNA maturation. So it will arrest the nuclear maturation, but there will be normal RNA maturation and it will lead to the normal cytoplasmic maturation. So due to the defective nuclear maturation and normal cytoplasmic maturation, there will be nucleocytoplasmic asynchrony. So all proliferating cells, including bone marrow cell, will be exhibit megaloblast. So megaloblasts have sheave-like chromatin in nucleus while increase amount of the cytoplasm. We will see image of megaloblast in further slide. First image showing peripheral smear, arrow showing macroovelocyte. So it is the cell like in oval shape, while hypersegmented neutrophils. So neutrophil have lobes more than 5, and also teardrop cells is present. In bone marrow, it is showing megaloblast. So we can appreciate nucleus have a sheave, chunny like nuclear chromatin, and cytoplasm is bluish in color and increase in amount. Hemolytic anemia associated with intravascular or extravascular hemolysis. There will be destruction of RBCs, reticulocytosis, jaundice, splenomegaly, and peripheral smear will show spherocyte, schistocyte. Left finding will show increased LDH and increased indirect bilirubin. G6PD deficiency detailed video with hemolytic anemia is available on YouTube channel, link given below. Is showing schistocyte or the helmet cell. It is seen in microangiopathic hemolytic anemia. The P is showing spherocyte. Spherical cells are seen. It is seen in hereditary spherocytosis and immature hemolytic anemia. The image showing stomatocyte. It is seen in hereditary stomatocytosis, liver disease, and alcoholism. The image showing bite cell. Bite is created in the RBCs. It is seen in G6PD, glucose 6-phosphate dehydrogenase deficiency anemia. To summarize this session, RBC disorder is equal to decreased production, increased destruction, or the loss of RBC. Morphology tells the story. Small, normal, or large RBC. Always correlate smear with indices with clinical features. So for microcytic, Sita, for normocytic acute blood loss, and for macrocytic Lahore Medical College. Take home messages. If you found this video helpful, hit like and subscribe to Pathology Pebbles. Comment below which topic should we simplify next. Thanks for watching.